Hello and welcome everyone to tonight's educational webinar, which we are so excited to present. Thank you so much for joining us for this evening's session. We're super excited to be running tonight's session on Beyond the Do's and Don'ts, Empowering Prenatal Clients. And it is delivered by one of our phenomenal educators at Unite Health, Jess Jenkins. So before we kick off in tonight's session, I am Sarah Todd. I am the owner of Unite Health, and we are the leading provider of Pilates teacher training in Australia. We are so excited to be delivering this session for you, and we hope you get so much out of it, so many takeaways from our phenomenal educator, Jess. We hope and we aim for you to stay on to the end of the session, as we are giving away a free course place on our anti and postnatal mat work and reformer online course. So please do make sure you stay to the end of the session, and we'll be drawing that tomorrow. And we do also have a little surprise for you at the end of the session. So let's kick off. I'm really keen to dive straight into the evening session with Jess. So before I introduce Jess, just a little bit on her amazing background. Jess is a Unite Health Educator, a Pelvic Health Physiotherapist, a Pilates Instructor. She's known on Instagram as the Mama Physio, where she shares her passion for pelvic health and supporting women through every stage of motherhood. Jess is a highly experienced physiotherapist, an advanced practice physiotherapist with extensive experience in both public and private settings across both Australia and the UK since graduating in 2012. Her areas of expertise include pre- and postnatal care and clinical Pilates. She has over 15 years experience both participating in and teaching Pilates, from one-on-one rehab, group classes, and fitness classes in gyms and studios. Jess's APPI training has laid the foundation for her approach to rehab and whole body wellness. On top of this, Jess also runs an online studio, Move with the Mama Physio, offering specialized pre- and postnatal Pilates class. Jess is a powerhouse and across so many things, and we're so excited to have her here. Outside of work, Jess enjoys spending time with her beautiful daughter and husband, and is often spotted in coffee in hand while checking out her local Pilates studio. We're so excited to dive into this session tonight and welcome Jess, and hope you guys get a lot out of it. So please welcome Jess.
Hello. Hi, everyone. Thank you, Sarah. That was such a great introduction. I feel very flattered. Yeah, thank you so much for having me today, and let's get into this webinar. So let me just share my screen. Go into slideshow mode. All right, so thank you everyone for joining me today. I'm going to be taking you through a webinar that's titled Beyond the Do's and Don'ts, Empowering Your Prenatal Clients. So thank you, Sarah, for the intro. Don't need to go through this again. So firstly, let me just talk you through like a common scenario that I will see. I probably say even myself attending classes. I don't think Sarah mentioned as well, I'm actually currently 24 weeks pregnant with twins as well. So I was actually saying earlier, I'm finding it really hard to find pregnancy Pilates classes near me. So hopefully, you know, out of this, people are starting to get a bit more confidence to start running classes at their local studio as well. But a common scenario that I see from my patients, especially, are that classes are completing unsafe exercises. The classes are boring. They're avoiding complete areas of the body, such as like your abdominals and core area. It's repetitive. It's causing pain or discomfort, or there's an inability to adapt for different gestations. So like the class needs to be suitable for someone who's 15 weeks pregnant, but also, you know, 38 weeks pregnant. So our goal today is to empower you and your prenatal clients and shift the focus from what can't we do, like restrictions, to empowering these patients and a client, sorry. So to do this, I would like to think that you would be really confident with what is confident, with safe and unsafe for exercise in pregnancy. understand the pelvic floor and incorporating the pelvic floor into your classes, and know about common pregnancy conditions and how we can prevent and manage them. Now, I've included the pelvic floor here because I feel like a lot of people kind of go, well, we don't need to incorporate that into a class. We're already doing core work. But from my perspective, I work with prenatal clients. I probably see at least like 10 pregnant women a day at work. And I am constantly having this discussion with them that what are you doing for exercise in pregnancy? Well, regardless of what they were doing pre-pregnancy, CrossFit, walking, yoga, nothing. The moment people find out they're pregnant, they all want to do Pilates because they know they need to have a strong pelvic floor or keep their body strong, pelvis strong. And so that's why they want to do Pilates. So it's really important to be incorporating and making sure that you're cueing this properly in the class so that these patients are getting the benefits out of the class that they're attending it for. So firstly, let's just debunk some common pregnancy exercise myths, because I feel like this is still something to this day that there's so much confusion, especially online. We see stuff from different countries, and we'll kind of go a bit more into that. So the first one, which is probably the most talked about, is when should you stop exercising on your back? So I feel like it's a controversial thing, and let's talk about why and the reasoning why there is a point in the pregnancy where you don't want to be exercising on your back. So there's this thing called vena cava compression. So if you're thinking on your left side of your body, you've got your heart. Your heart pumps the oxygenated blood through the aorta in through your body, and then all that deoxygenated blood comes up through your vena cava, which is like a big vessel that's really like squishy. So if you lay on your back, your baby and the weight of the baby would actually compress that. And what that would mean is that you would get less blood back to your lungs to oxygenate it and back through your body. And that can mean that your baby gets less blood as well as the mum. And you might feel symptoms of like dizziness, lightheadedness, etc. So that's why there is a point in our pregnancy where you can't sleep on your back as well, and you should stop exercising on your back. Now, this is where the confusion comes from, because every country and governing body just seems to have something completely different online. So if I have a look here, the UK's says 19 weeks. America is from 13 weeks. And also there's another governing body in America that says from 20 weeks. The Canadian guidelines are just if you're symptomatic. The Royal Women's Hospital here in Melbourne fact sheet says from 16 weeks. AusActive, one of the governing body, one of the fitness bodies in Australia, says from 16 weeks. The Australian Government Department of Health says from 28 weeks. And RANZCOG, which is like the governing body for obstetrics and gynecology, GPs and things, says from 13 weeks. So you can kind of see why there's like such a discrepancy online about when you need to stop. I think at the end of the day, you have to be able to justify what you're doing. So from my personal opinion on what I think I would be doing if I was running a class. So the two top ones are the more evidence-based guidelines. The other ones have just kind of come out of nowhere. So they've just kind of like popped a number. There isn't any evidence to back their recommendations on the website. So I would be thinking that if I was running a class that is suitable for all pregnant women, so a prenatal Pilates class, I probably, just to make sure it's suitable for anyone at like 35 weeks and 15 weeks, just do the same for everyone, and then just either use a wedge, bolster, or not go on the back at all in the class. If you're running a class where you have the ability to like modify for specific people, then I would use your common sense between that like 13 and 28 weeks. How do they feel? Are they getting lightheaded? Et cetera, et cetera. Like if I'm using myself as an example, with my first pregnancy with my daughter, I was pretty fine, like exercising on my back to 27 weeks. I'm currently almost 24 weeks pregnant with twins. And I reckon from about 20 weeks, I've been like seeing stars when I lie on my back for exercise. So it's really different. And it is like a real threat to actually think about, but it's more just like getting feedback from patients as well, and depends on your setting. Another exercise myth we hear is like, you had to keep your heart rate below 145 beats per minute. This is false. This is actually like a guidelines in America. It's not a guidelines in Australia. Firstly, we don't want to be relying on a heart rate because it's unreliable in pregnancy. So in pregnancy have this thing called a physiological anemia, which is when your heart rate really increases in pregnancy because we are pumping more blood around the body. We're trying to pump blood through a baby, through a placenta and everything as well, increase cardiac output and everything. And we also have a decrease in our diastolic blood pressure. But because of all these changes, because of that increased blood volume, it actually dilutes our blood cells in our body, which is called the physiological anemia, which means there's less like oxygen being carried around as well. And overall, the implications is that like your heart rate is just unreliable. I, for myself, like would walk upstairs and my heart rate is definitely over 145 beats per minute very easily now that I'm pregnant. So what we like people to use is the talk test. And we are allowed to exercise vigorously as well, so getting breathless. So essentially, rather than being like a range of your heart rate, I would just go based off how you feel. So for moderate intensity exercise, you should be able to hold a conversation, talk back to your instructor while you're exercising. In vigorous, you would find this difficult. Obviously, if the person's getting like quite breathless and needs to like sit down, they're probably working too hard. Lifting heavy weights, I'd like to think people are up to date with this one, but I still have patients. I had 2 patients today that told me that they've been told that they shouldn't be lifting weights in pregnancy. So this is false. Just to show you one study that came out really recently, which talks about lifting heavy weights in pregnancy. This study specifically had pregnant women who did barbell back squats, bench press, deadlift at 70, 80, 90% of their 10 rep max with free breathing and also Valsalva, like a breath hold. And what they were measuring was the mum's blood pressure, heart rate, and the baby's heart rate and the blood flow in the umbilical cord. And they found that the lifting protocol was tolerated really well by both the mum and baby. So I think like this, obviously this isn't Pilates, but like this is like so much more high intensity than Pilates, or like probably what the majority of people are doing at the gym. Like I have patients, they go, yeah, I'm doing strength training. I'm lifting like 5 kilo weights. I'm like, that to me, strength training is more like lifting your like 80% 1 rep max, for instance. So I think this is like promising for patients who are wanting to lift a little bit more. You should avoid twisting movements, false. There's actually no evidence behind this whatsoever. This comes from yoga teacher training where they're told to avoid twisting movements in pregnancy. And they thought the theory, I was Googling it, was something around like torsion through the uterus or injuring the baby, for instance. I can tell you now, the uterus is a thick muscular wall. It is so protective. Twisting movements, if anything, like it's not going to do anything. It's not going to squish the baby there. And if anything, if we stop doing thoracic mobility and spinal mobility exercises in pregnancy, we're going to be pretty sore. Our spine needs to move for us to have like a healthy, pain-free body. This is another controversial topic, which I would like to think people who are like staying up to date with evidence would kind of have an idea about this now, but it is false that you should avoid abdominal exercises as this will cause a DRAM. A DRAM is like an abdominal separation. So let me just talk you through a DRAM first, for those who don't know what it is. DRAM is like an acronym for diastasis of the rectus abdominis muscles. So if you think of like your six-pack muscles, there's a ligament down the middle called the linea alba. And as your baby grows, it is normal for your six-pack muscles to like stretch this way and then stretch this way. They also become wider as well to accommodate for the baby. Up until, honestly, like up until like 2-3 years ago, we used to think that doing abdominal exercises, so like sit-ups, Russian twist, pile-off press, planks, things like that, would contribute to a DRAM. And like, that's what I was teaching as well, because that's what we had been taught. But in saying that, it was like there wasn't really much evidence behind it. It was just like something that people just generally had this assumption about. But there's actually been really good amount of evidence recently to disprove this. So let me just show you two recent studies that talk about this. So this study was December 2023, and it essentially looked at pregnant women at 2 points in their pregnancy. So at 27 weeks and 37 weeks gestation, with a DRAM that was bigger than 2.8 centimeters. So probably like 3 fingers width at that point. And what they did was look at these exercises. So you don't have to read it all, but I'll explain. It was just like your basic pelvic floor, TA activation, adding them together, a crunch, a curl, a head lift, a oblique abdo prep. And then they got people to do like an abdo prep with a pre-activation of the pelvic floor and the oblique prep with that as well. And they actually found, interestingly, which is something we've kind of like, as a physio, I've known this for a while because I use ultrasound in clinic and things, but it's nice to see it solid written down in studies, that the pelvic floor and drawing in, so like a transversus abdominis exercise, actually increases your interecti distance, so the gap between your six-pack muscles, whilst doing things that shorten your recti muscles like a crunch, head lift, oblique prep actually decreases this, which makes sense. Like it makes so much sense. If you think about like the anatomy in that area, your transversus abdominis fibers are horizontal. When it contracts, we know that it like pulls on the midline and does this. So what's it going to do when someone's pregnant and has a separation? It's going to pull the separation apart. What's going to happen when we add a crunch in? It's going to pull that back in together. So, I feel like this is just so nice to see this written down, and like one of those things that pops up that makes you go, you know what, we shouldn't really be fearing doing these type of exercises in our prenatal classes. I've just made a comment down the bottom here about doming. So there's absolutely no comment about doming here. I personally think it depends on the type of doming. I'm not going to go into it, but essentially if it's soft doming and it's squishy, I'm not really concerned about it. And then here's another study that came out after that one. So this was in 2024. And this is just looking at pregnant women doing abdominal and pelvic floor exercises during pregnancy and whether it increased their diastasis recti. So they did like a 12-week program, and they're assessed at the start of the program, after, and at 6 weeks postpartum. And just to like see the exercises, they're pretty basic, to be honest. Like it's not the type of stuff we're really doing in our class. But like if we have a look, the third one down is a sit up in a sling. Like that's probably something similar to what we might be doing in a class. Actually, number 2, the forward lean with arm activation, is probably a bit more like a kneeling knee stretch or a kneeling arm stretch. Sorry, yeah. So, or like your cat arms or something like that. And then looking over here, number 6, like your sidearm series, pile off press type exercises. 7's like a single arm overhead press. 8's squat to overhead press. And then the last 2 are just like an abdominal pelvic floor lift. But what they found is this specific program had a negligible effect on the interecti distance when comparing to a group of women who didn't do it. So I think like obviously that's not the exact same exercises we're doing in a Pilates class, but it's pretty promising, to be honest, those 2 studies, to think like, yeah, why not? Let's start adding in a few like rollbacks and things into this population group. And again, I think like abdominal shortening exercises, doming has not been mentioned again. And like I said, like it depends on the type of doming as well. So overall, I think like we shouldn't be scared of abdominal exercises. And I feel like these can be safely continued until late pregnancy. I feel like I'm using myself being pregnant at the moment as like a guinea pig with this, because my first pregnancy was when everyone was like, do not do them. And I stopped doing the majority of those things early, but like I'm still trying to do crunches and things like that and will report back. But yeah, it feels good. And just remember as well that we shouldn't be doing exercises completely flat on our back in the last trimester. So we might need to use a wedge or just modify doing it on a fit ball and things like that too. All right. I'm going to talk about the pelvic floor now. Just a bit of an overview of the pelvic floor. This here is an image of like a pelvis looking down into the pelvic floor. So not from the outside, it's from the inside. And the main thing I want you to see from this is that the pelvic floor is not one muscle. I feel like a lot of people have this idea that it's just like one muscle from front to back and it's just like a little thing. It's actually like a bowl. It goes from the front on one side. You kind of see it like loops around your urethra and back, the vagina and back, around the anus and back, goes up to the sides, up to the hips, and then up through the back as well. And it's not just muscles, there's fascia, ligaments, nerves, tendons as well. There's skeletal muscle in there, which means we should be really training it in a way that we do the rest of our body, and incorporating it into functional movements. It has a role in continence, sexual function, core stability, and childbirth. Now, why should you incorporate pelvic floor into your class? Like I said earlier, like firstly, I feel like a lot of women, actually, no, I would say 95% of my patients, when I say, are you doing pelvic floor exercises? If they're doing Pilates, they go, yeah, I'm doing Pilates. To me, that's not doing pelvic floor exercises. To me, pelvic floor exercises is like you're doing something individualized, you're focusing on squeezing that specific area. But these women think that they are. So we should be incorporating it into the class. Um, some stats for you. It's so common to leak in pregnancy. So up to 60% of women, like 1 to 2/3 of pregnant women will leak during pregnancy. And the evidence tells us that if you do pelvic floor exercises in and before pregnancy, you're way less likely to have leakage in pregnancy and after. And the other thing that's quite interesting as well is those who have pelvic girdle pain, PGP, the evidence tells us that they actually lose the synergistic action that we see between like your deep abdominals and your pelvic floor. So if you have a patient who's got a bit of like back hip pain in your class and you're telling them to draw their belly in, they're probably not contracting their pelvic floor because they've lost that synergistic action and they're like leaving it behind. So it's important to think about cues there too. So how would we include it in a class? Firstly, I'll come back to the cues, but dosage. So when I'm giving pelvic floor exercises, we want to be thinking of like our endurance, strength work, which is like long hold. So that would be like doing, for instance, like a 10-second hold or a 30-second hold, for instance. You don't have to do it with every exercise. Okay. So you don't have to think like, oh my God, okay, hang on, this exercise, when am I going to cue the pelvic floor? When am I going to do it in this? I would just pick a few exercises in your class that are suitable and just do it during that. Because, if your class is 45 minutes, I don't think anyone can hold their pelvic floor for 45 minutes based off what I see in clinic. So I would generally say like you could do it with stretches. Like when people are sitting, stretching their glutes, all right, let's now try and hold for 30 seconds whilst we're sitting here stretching. And then you know that you're going to get in a few different reps when you're going for both sides of the glutes, for instance. Or what you might do is go, okay, when we get to this, to like the squats component of our class, or let's just do it with our chariot pulls, for instance. Let's just add it into them. And then you can kind of like just leave your normal cueing for the rest of the class. I also like to include quick lifts. So going on, off during certain parts of the movement. This does not work on strength. just so you're all aware. If you're just going on off all day, you're definitely not going to get stronger, but you're going to be really good at switching it on and off. I would just incorporate this generally in functional movement. So you could, like, standing abduction, your scooters go on as you push back, off as you return, for instance, or a bridge. Lift your pelvic floor as you rise, relax as you lower. So just pre-think of it in the class rather than every single exercise. And don't forget about relaxation. That's also really important too. And everyone should be breathing. If someone is holding their breath whilst they're holding their pelvic floor, they're definitely doing it incorrectly as well. The other thing to think about, actually, I'm going to come back to cues. So previously, normally when I do a webinar like this, in person, I would go over a bit of a practical with cues, but we don't have time today. So what I'm going to do is just tell you my favorite cues, because I think it's really important to have like a variety of cues up your sleeve, because not everyone resonates with the same cues. So I'd say ones I always use would just be, it's squeeze your pelvic floor, holding on to we, holding on to wind. Maybe have a go doing them as I explain it, and you might kind of understand why you're like, oh yeah, I don't know how to do that. And then combine holding on to wind and we, front and back. Nice one, like imagine grabbing a tissue with your pelvic floor and like pulling out of the tissue box and then dropping it back down. Or another one might be like grabbing a straw and sucking up the straw. Okay, there's just a few, there's so many more, but you can kind of see if you tried those, it kind of like all elicits like a different type of muscle contraction. So it's just something to think about. The last point here is just consider your type of learner. And this is where the different cues come in. Like, is this person a visual learner? Do they need like really good visual imagery? Auditory, do you need to be really good at explaining? Or are you that person that can just do this and someone's already contracting, Tactile, are they better off actually visually looking for a bump lift or feeling like their pelvic floor lift up off the box when they're sitting and things like that. So just something to think about in your class. And then just a final point on pelvic floor cueing is that the research shows us that 50% of women aren't contracting their pelvic floor muscles correctly following verbal or written instructions, and 25% use a technique that could weaken their pelvic floor. So just feel like, if in doubt, if someone's like bringing it up or telling you they're leaking or blah, 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 I would just refer onwards just to like get them checked properly. They can get the technique checked and then they can come back and you know that they're doing it right in the class. All right, last point for today. We're speeding along to make sure we kind of cover everything, little thing, just the most important things. But common muscular conditions in pregnancy. The main ones I would see would be pelvic girdle pain, pelvic girdle pain, pregnancy low back pain, and like thoracic upper back pain. So we're going to talk about those. Firstly, pregnancy-related lower back pelvic girdle pain. Now, these are so important to know about because you're going to have someone in your class who has this because they're so common. Statistically, 44% of pregnant women in Australia will have pelvic girdle pain. I'd say it's probably even more, to be honest. I'd say most get some degree of it at that one point in their pregnancy. And it refers to pain or discomfort felt in the pelvic area. So if you look at this image of the pelvis on the right side, it could be at the front, it could be in the pubic symphysis, could be in the back in the sacroiliac joints, could be at the side, anywhere around there, and it could be like jumping around. So that person that comes in and is like, I'm getting lightning crutch, or I feel like I'm being jabbed up the front, versus the person who's got really sore hips when they're walking, it's both pelvic girdle pain. And that's an umbrella term. Other terms you might have heard is like pelvic instability, symphysis pubis dysfunction, sacroiliitis, SIJ pain. People self-diagnose sciatica, it's generally pelvic girdle pain. The classic signs and symptoms is someone who's getting like sharp pain in the class. So they're going to be sore getting on and off the reformer, getting it up and down from like sitting, standing on one leg, stairs, walking, getting dressed. So it does have like a big implication for like if you need to have modifications in your class. Now, if we think about the cause, um, so I feel like pelvic girdle pain gets a bad rap from the hormone relaxin. The evidence tells us it's not the cause. If it was the cause, 100% of pregnant women would have pelvic girdle pain because every pregnant woman gets relaxin. So we now know that generally it's related to some type of asymmetry around the pelvis. And my like little antenna pops up there and goes, okay, so that means if I was working in a clinical setting with this lady, we need to correct that asymmetry. Okay, so one side's weaker, one side's stronger, one side's tighter, for instance, let's say. There's also a link with generalized joint hypermobility syndrome. So people who have like double jointed elbows, knees, things like that, people who just consider themselves quite hypermobile are more likely to get it as well. So we're thinking about what we can do in a class that's going to help these women firstly and what we need to avoid. Let me actually come to the last point there. So the most common exercises to aggravate pelvic girdle pain are going to be those single leg exercises. So it's going to be like scooter, standing abduction. I've put a little asterisk there because it's standing abduction if they're not evenly weight bearing. Because I'm sure as instructors, you all know what I mean. There's that person who can like, you watch them from behind when they're doing a standing abduction, their pelvis and everything just looks symmetrical. They're pushing out evenly through both legs. And then there's that person whose hip like hitches as they push out and you can tell that they're like pushing more with their left leg or something like that. They're the people who have like some asymmetry, which is like so obvious when you're looking at it. Standing adduction for the same reason. Lunges, because that's single leg. Side lying feet. So side lying work that's open chain. So like any feet and straps exercise generally is going to aggravate them. And open chain, like 4-point kneel exercises. So like 4-point kneel swimming or bird dog. So just to kind of like know exactly what's going to aggravate them, but then also we're not thinking like restrictions. We're thinking, what can we actually do with these women then? And what are we going to do that's going to help them? So I always explain to my patients, a healthy body in pregnancy is a really, really, really strong and stable pelvis and a really mobile spine so that when we move, the movement's coming through our spine, not through the pelvis. So firstly, like we want to be making sure there's lots of thoracic and spinal mobility. So, arm openings, thread the needle, mermaid, sidearm series where there's like some rotation incorporated into your body are great. Or even like the single unilateral work in kneeling, things like that are going to be really good for these women and should be generally completely fine for those with pelvic girdle pain because they're working kind of their upper body as well. And then you're kind of thinking, well, okay, we worked on that spinal mobility. What can we do to stabilize around the pelvis? We normally want to be focusing on things where there's even weight bearing in the legs, which is why like your banded hip works good, like your banded squats, standing adduction, if it's done properly. Like I feel like in a clinical setting where you can really like hold them and give them tactile feedback and change the springs and stuff can be really good. But in a fitness setting, like it might just be too much. Sometimes the best thing to do is just get them off the reformer and get them doing like squats next to the reformer if they're like literally struggling to do the majority of the exercises. And then lumbopelvic stability exercises, any of your lumbopelvic stability exercises. I feel like with these women, a lot of the time I'm thinking sling work. So AOS is anterior oblique sling, POS is posterior oblique sling. So just things that stabilize across the back and the front of the pelvis. I really like doing like my back plow, chariot, pulls, rows, single arm rows, lots of those, like working a bit more up here to stabilize across the pelvis. Yeah, and it's more just kind of thinking, what is the goal of this exercise with these women? Then let's move on to pregnancy-related low back pain. So if we're kind of comparing back and pelvic pain, pelvic girdle pain is sharp. The patient is going to be like, oh, this movement is like a knife stabbing, or it's like closer to like a 7 out of 10, for instance, with movement, and then they're still and it's gone. Lower back pain tends to be like generalized ache. It's probably more of like a fatigue type sensation. And it tends to be with prolonged postures, prolonged sitting, prolonged walking, prolonged standing at the end of the day. Generally, the cause is related to like stiffness, weakness throughout that whole area. So when we're thinking about how are we going to manage someone, especially if you're thinking like you're working clinically with a patient, this is what we want to address. Again, you're kind of thinking same as previous. Spinal mobility is so, so, so important. And then just generalize like strength around their body. So similar to the pelvic girdle pain, like we want to be doing lots of thoracic and spinal mobilities. Like I swear every single one of my patients is doing arm openings at the moment, especially with like a weight in their hand is really nice. Lots of mermaids, lots of thread the needle, child's pose to the side, like things like that. Abdominal and core strength. So like really nice ones for lower back pain is like your cat arms, your cat legs, kneeling knee stretches, if they can do a standing knee stretch, things like that as well. And they kind of fall under both categories of like abdominal and core strength and lumbopelvic stability as well. So really these women with lower back pain, they're just weak. We just need to strengthen them and restore that movement in their spine. If we think about the most common exercise to aggravate them, it's really because of the weakness. It's just if the springs are too heavy. So these women are quite easy to change in the class. Just put their springs right down. Just, rather than doing like 2 reds for an exercise, bring it down to a red or like go even lighter. And then at least they're just moving. All right, our last common condition is thoracic or rib pain. So this is literally pain anywhere around your rib cage. I'd say the most common areas people would get it is like around the bra line, and they'll generally feel it either at the back where your ribs meet the spine, or they'll feel it on the side, kind of underneath their armpits where the bra line is, or they'll feel it at the front, and they'll generally only feel it on one side. They might feel it on both. And the pain with thoracic areas tends to like follow a rib. So even if someone's getting pain at the front of the ribs, where they meet at the cartilage there, normally as a physio, if I was treating it, I'd be like following the rib around to the spine and working on it in that area. So yeah, symptoms tends to wrap around. I tend to find the worse it is, the more it refers. Otherwise, it tends to be more at the back. It can vary. It can be like dull. Sometimes it's really sharp. Actually, I don't know of the prevalence of it, but I'd probably say like majority of women get it late in their pregnancy, around that point when they're like really starting to feel the baby like up underneath their ribs at around like 30 to 35 weeks. And then they wake up one day and they're like, it's gone. And it's because the baby's dropped and they've got that more space at the top there. Generally, the cause is stiffness. It's like, obviously, like there's the displacement of all your organs and everything being pushed up, which happens to everyone in pregnancy. But it's generally stiffness and postural. So those people that like sit at a desk all day, driving a lot at work, those who have bigger breasts and things like that as well. So you're kind of seeing a trend here. What do we want to do in our class? Lots of thoracic and spinal mobility for these women. We need to move both sides, lots of rotation, lots of side bends, even adding some strength into that mobility work as well. So all of the previous exercise I've talked about through there. But we also want to add in some scapulothoracic stabilization because I feel like because these women, the majority of them tend to be in like sedentary jobs, generally they really need to strengthen their upper body. Lots of like back work, posterior oblique sling, rows, anything like pulling type movements will be really good for these women, as opposed to things that work their chest. Like I find things like, for instance, push-ups, or like pushing type movements that tighten up through the pecs actually tend to be a bit detrimental to these women because it makes them tighter at the front of their body. So we want to do things that like open up through the chest and strengthen through our back for these women. And then I've added in hip and pelvic mobility because, we're thinking of the whole body as a big complex. We're not just looking just in that area. These women tend to be really tight in the hips as well. They tend to be tight just everywhere. So like incorporating spiky balls, massage balls, things like that into your class as well can be really, really helpful. So just kind of like summing up everything here that I've quickly gone through, I'd say these are your key elements of an effective prenatal class. So firstly, I encourage you, because I know most of you don't do this, to incorporate the pelvic floor into your class, and your mums will appreciate it. When you have a baby, you will appreciate it. Make sure in your class planning you actually have some thought process behind it about like the goals of the exercises. So like incorporating thoracic and spinal mobility, scapulothoracic stability, lumbopelvic stability, pelvic and hip mobility, and abdominal core strength. So kind of like making sure you've ticked off all those things in a class rather than just like body parts or just like, oh, what area do I do next? I'm on the left side of the reformer. And an effective class needs to be suitable for all gestations of pregnancy. So when you run a prenatal class, you need to give options of springs, so that it's suitable for someone who's like weaker, in pain, further along in their pregnancy, feeling really fatigued, having an off day, but also suitable for those people who are like 15 weeks, feeling really energetic, really bummed that their regular class won't let them attend because they're pregnant and they still want to get a really good workout. So just having that variety. Then last point, whilst also making sure you're modifying exercises on your back if it's appropriate for like your setting as well. So like there's lots of different things to think about, but like this should come off like that when you're running a class, when you're doing it really regularly as well. So just recapping everything, I think the main thing is that you want to be empowering your patients. You want to make sure that they're moving. Women get really scared to move in pregnancy because everyone's trying to like bubble wrap them. So empower them. Remember, movement is medicine. Anyone who's sore, like they generally feel so much better after they've come to a class and getting stronger and things like that. But also remember, every pregnancy is different and you've got to be adaptable with your programming. Great. That's everything. I am going to hand this back over to Sarah.
Great. Thank you so much, Jess. Oh gosh, you are so wonderful and informative. We are so appreciative of that session, Jess, and we hope everyone attending got a lot out of tonight. I know we only have a limited time, otherwise we could keep going and going, but we're super excited to announce that we do have a $200 discount available on our anti-postnatal mat work and reformer course bundle that's available to everyone, and it will be available for the next 48 hours. So the code for this is APN webinar, but we will have this in your inbox as well, plus the recording tomorrow morning, so you can recap on everything. So just to recap, that's $200 off our anti-postnatal mat work and reformer online courses, where you'll get to see Jess present more on both topics. So just a huge thank you to Jess. We just adore you, and we hope everyone got a lot out of the session tonight. And we will be announcing the winner of the anti-postnatal course bundle in the morning as well. So we'll contact you directly and get you enrolled onto the course. So Thank you so much to absolutely everyone. We're seeing wonderful messages come through, and we're just really appreciative and hope you can implement this with your clients. Hopefully starting tomorrow, or we see you on an online course with us soon. Great. Thank you so much, everyone.
Thank you. I'm reading everyone's thank you, so really appreciate it.
Thanks, guys.